Welcome to The Pulse, the official podcast of the Georgia State Medical Association.
Hello, everyone. Thank you for joining me once again. I am Dr. Julianne Adams Birt, the current president of the Georgia State Medical Association and tonight's host. And I have joining me Dr. David Blake. He is a colleague and somewhat of a mentor because he has been running this race and taking care of patients and in leadership for several years before me. But let me tell you about him before we bring him on. You're going to see how dynamic he is. Dr. David Blake is a native of the Bronx, New York, and he graduated, however, in Atlanta from Northside Performing Arts High School after his family relocated here. Dr. Blake received his BS from Howard University in Washington, D.C., HU, and earned his MD degree from my alma mater at Morehouse School of Medicine in Atlanta. He completed his internship and residency in family medicine from Morehouse School of Medicine's Department of Family Medicine, serving as the chief resident during his final year. He has also completed a fellowship in faculty development, MSM Department of Family Medicine. He is an adjunct faculty member of the Department of Family Medicine at Morehouse. He has been recognized as Morehouse School of Medicine's National Alum of the Year and has served as president of the National Alumni Association. He is the medical director for Family First Healthcare PC in Lithia Springs, Georgia, where he provides clinical preceptorship training to medical students, nurse practitioners, and physician assistant students. Through the Atlanta Medical Association, Dr. Blake mentors college pre-medical students. He is an associate medical director for Vitas Healthcare's Atlanta program and speaks for the end-of-life Nurse Education Consortium, having presented nationally and internationally for the National Medical Association, the Georgia Academy of Family Medicine, the Georgia State Medical Association, the National Black Nurses Association, American Men in Nursing, Chi Eta Phi, Nursing Sorority, Black Nurses Rock. Dr. Blake, what have you not done and where have you not been? He is presently the chair of the Georgia State Medical Association Board, and he is the vice president of the 501c3, our foundation for the Atlanta Medical Association. Whew. You have done a lot, and I'm not finished. Dr. Blake has served as ringside physician for the Georgia State Boxing Commission, covering boxing and mixed martial arts events throughout the state of Georgia. Most proudly, however, and I don't know, it's hard to top all of those accolades, his leadership, his mentorship, but he is most proud of being the father of 4 beautiful daughters and a grandson and a granddaughter. And we are so excited to have him here. You are a busy man, and I am so glad that we were able to snatch you up before you are off to speaking somewhere else, because he is always on the go. Welcome.
Thank you very much for having me on The Pulse. I appreciate the opportunity to be here with you, Dr. Adams Birt, and look forward to sharing some vital information for our audience this evening. Yes, and I am proud of those little girls and the heir to the throne, the grandson.
Awesome. So, all right, tonight's conversation is around end of life care. We're going to learn about the care. We're going to learn about when it is time to get the care for our loved ones, how we sign up for it. We're going to talk about advanced directives. We're going to learn what the difference is between palliative care and hospice care. Then we want to debunk some myths. because in a lot of our communities, a lot of our families, including mine, there's this misconception that if and when a physician starts talking to loved ones or the patient, him or herself, about receiving this care, they try and kill grandma off. So before we address any and all of that, could you just share with us briefly about hospice care, how it started, when it started, and all the things, and then kind of give us an idea of what the difference is between hospice and palliative care? Take it away.
Certainly. Well, I have had the opportunity to be involved in hospice care for the past 24 years. And during this time, I've had the opportunity to hear a lot of the pushback that you just described. And now, as you mentioned in speaking about my bio, what I have done on these most recent years is travel around the United States lecturing on end-of-life care and hospice and just these such topics. Hospice is actually relatively new. The current thought leader in hospice care, thought of as the mother of the hospice care benefit, is Dame Cicely Saunders. Dame Saunders is from England, London, and specifically, and she was a nurse at that time, wondering what was going on with the patients who were at end of life and did not really appreciate the care that they were or were not receiving. She subsequently went to medical school herself and came back and began the first hospice at called St. Christopher's in London in 1967. From that, she began to mentor other doctors and nurses, and leading to United States and Canada, for example. And in the United States, the first hospice was opened in Connecticut in 1974. And this time, hospice was a volunteer organization. So doctors and mainly nurses and clergy would take care of the patients at end of life. Carrie Meeks, an African-American woman, had just entered into Congress in 1978. And in 1979, as her first act of legislation, she presented to the Senate a bill that would later be signed into effect by then President Ronald Reagan, which has become the hospice care benefit that is still in place to this day through Medicare. Over these years, the benefit has now been taken over and brought into being with third-party payers as well. So that's how you get into some of the history of hospice and where we are. Now, hospice is specifically end-of-life care, meaning that when a patient has reached a point in their medical treatment that there are no more treatments that are going to cure the patient's disease process, when the patient no longer desires to receive such aggressive treatments, dialysis, chemotherapy, radiation therapy are some examples, when the physician can inform the patient that they've reached the end of curative treatment modes, that is the time to consider having hospice to come into place. And to debunk one of the first myths, hospice does not mean we're no longer going to treat the patient, does not mean we're not going to take care of the patient. It just means that we're going to change focus from trying to cure the patient to keeping that patient calm and comfortable as they go through this trying time of life. Most people want the end of life to be at home, where they're comfortable, where they've spent their lives and built their families and around their loved ones, as opposed to being in a cold, sterile hospital environment. So that is where hospice really comes into play, to keep that patient at home. I'll take a pause and see if there's anything more specific that you want me to further go into, because I can go on.
I know you can. 24 years in this field is just awesome. The question that I pose, I'm going to take my doctor hat off and just speak from a loved one's perspective. I have plenty of questions. And I've heard you talk before, but I've had plenty of questions. But the first question you just mentioned about hospice as when it started being a place that people go for, but now it seems it's kind of crossed over and it's an opportunity for people to stay home. So when and how is that decision made? Is it purely up to the patient, the family members? Speak to that for me, please.
Certainly. Hospice is actually a philosophy and not a place. You don't go to hospice, for example, though that is how some people use that phrase. Hospice is now being termed home hospice, and home is where that patient calls home. Their traditional home, an assisted living facility, a long-term care facility, and it can even be if somebody lives in a car on the street, which has happened before, but it's where that person lives and where they want to pass away is where they consider home. And that's where hospice care is delivered.
Mm-hmm.
And that decision is made by the patient and or the family based upon the patient's cognitive abilities to make their own decisions.
So how can someone hearing you at this moment, how can they decide for themselves before it becomes the duty of the next of kin? Is that something that can be placed on a legal document and help the conversation for those family members who feel like, I know you're trying to debunk the myth, but who feel like you're just trying to push my grandma into the grave? Is that a decision that can be made now before someone even gets to that point?
Yes, and that is a very important decision to make as early as possible. And remember, none of these decisions are final. They can be changed along the way. So if a decision is made about hospice care, medical care today, in 3-4 months from now, a change needs to be made, it can be done. This is a conversation that most people, physicians included, do not like to have, do not want to have, and it's called something we use difficult decisions. So goals of care is the first thing you want to think about. With the patient specifically, what do you expect? What do you want to happen? How do you want us to proceed? And with the family members intact. Going through those goals of care, you get permission from the patient to find out what they already know about their disease process. You
Mhm.
ask them then, would you mind if I give you some more information? Pretty much trying to debunk the myths, tell what's really going to happen with the patient, and let them now make an informed decision. And from these goals of care conversations, you can then develop what's called an advance directive. And the advance directive is a legal document that will lay out what the patient wants to have done for them as their disease process proceeds, as they lose their abilities to make decisions, that they can have happen things the way that they want it to happen, such as a do not resuscitate order. That is not mandatory to be admitted into hospice care. It definitely is probably considered beneficial, but it is not mandatory. And the patient can then determine ahead of time what they want to be done for them at that time.
Mhm. So, okay, so I was thinking all these hospital shows where it's just dramatic and everyone's in the room and somebody is, no, and you're trying to take mommy away and you're trying to do this and that. Can we just, if we sign that advance directive, does that paper hold? How long does it hold? Um, can the next of kin petition a court? All of those things. Like, it seems such a clearly a sensitive conversation, but is it that advance directive holds as long as we know and have proven that the patient was in their right state of mind, they were not, they weren't suffering with dementia. Like, give us that take on it.
Well, yes, that document does hold, but of course, anything can be argued and debated at any point in time. And that's why it is very important to have the family members, the next of kin, available for this decision-making conversation so that they understand and will know that, yes, this is what their loved one wanted to have happen. You were
Mhm.
present when it was brought up and discussed. It is now documented. And it is also thought that when you have an executor for your advance directive, you do not choose a loved one necessarily. You don't choose your spouse. You want to find an individual who you know will respect and uphold your decision.
Yeah.
So it can be a good friend, it can be a child, it can be a relative, but usually it's not the spouse. And then depending upon the rest of the family and their thoughts, you might need to go to a close friend.
Hmm. Hmm. And that makes sense. And so I got two questions. The first I was thinking is, what age do you have conversation? I want to know how you operate in your space with your patients. What age do you start having a conversation around advanced directives? Do you wait until someone has some chronic disease and they're on dialysis? Or do you have that question? Have that conversation sooner rather than later? And then my next question is like, who should be having those conversations? Which patient physician relationship is that best set in, right? So they've been your patient for 30 years, but now because of cancer diagnosis, they're going to the oncologist. You know, should I be having that conversation, or do I pass that on to the doctor who will likely be on the death certificate?
All right, well, let's see if I can put all that in order for you. There is no specific age to begin having the advanced care directive conversation, but if you had to put one on there, you would use the age that you consider the person to be an adult, 18, 21, because unfortunately things happen tragically. And these decisions sometimes have to be made in 20-year-olds. So the earlier that you have the advanced care directive conversation, the better. As I
Mm-hmm.
go around doing a presentation to nursing and physician organizations, it's amazing how many of us in the healthcare field have not filled out our own advanced care directives and need to do so. So
Right.
at any time, you can have that conversation, keeping in mind, as we said, you can change that, alter it, amend it at any point as you continue to go forth in life. But having something documented at each stage is probably ideal.
Mm-hmm.
Now, who should have this conversation as the physician clinician? Whomever knows the patient and families best. Because yes, if you have been a family physician, a gynecologist, primary and women's care, internal medicine physicians, unfortunately pediatricians as well, when that patient goes to a specialist, they're meeting that specialist for the first time. And to now have to have that conversation with somebody they may have just met or only seen once or twice would not be the same as with somebody that they've entrusted with their care for the previous years.
Mm-hmm.
So family physicians, internal medicine physicians, and now nurse practitioners are even trained in having these goals of care and advanced directive conversations.
Okay. So, as a gynecologist, I would just be honest that I have not put that in as part of my wellness visit and questions. So, can a patient who's advocating for him or herself, is there a document here in the state of Georgia where they can go that you know of and, bring it to their doctor? And then who is signing off on that, right? And then where does it get filed?
All right. Now, there are documents. One that is often used is called Five Wishes. In there, you list your five wishes, which can outline again to be resuscitated, not to be resuscitated, to be intubated, and other potential components of end of life care. And that's documented. And where it's filed, well, signing off on it is going to be the patient themselves, and most likely whoever's chosen to be the executor and or caregiver of that patient. Where it gets filed, believe it or not, the thought is to put this type of a document in a sealed plastic wrapper baggie and in the freezer. That's
Oh, wow.
someplace where even EMS has been trained to look for important documents if they get called to the home in a time of
Mhm.
distress.
Wow.
Mhm.
Wow. Okay. I'm learning a lot. I hope everyone in the audience is really taking this in because I am learning from you, Dr. Blake. Thank you. Um,
And as a
it,
gynecologist, you might be the first person to tell the poor unfortunate woman that she has a cancer of some sort, ovarian, cervical, uterine. So being able to have that conversation, would be something special to come from you as well.
Absolutely. And I am going to promise that I'm going to do better, because what you said about the age is important, right? When you have these conversations beforehand, um, even pap smear is normal, but hey, we just want to know you've been my patient for 5 years, for 20 years, whatever the case may be. And it's hard conversations, but let's have these conversations. And the reason why I started at the onset telling you how this was near and dear for me, because unfortunately, in the last 4 months, personally, I have lost family friends. I am, and I hate to count it off, but I'm at number 9 in 4 months. And the truth of the matter is, I would say at least half, maybe 4 to 5 of them could have and should have had some end of life planning. And the tension in families, to watch that is so disheartening. So if we have these conversations before the person is at end stage, cancer, end stage kidney disease, end stage liver disease, I think it will go over better. So I'm hoping our audience is taking this in. And something you said, I think this was even before the pandemic, Dr. Blake. I remember hearing you speak, and your company was sharing about the differences between the majority of Americans, Caucasian families, calling on hospice for hospice care versus African American communities. Could you just share that? Because I've been trying to be you and share that in my own circles, with my family, and it's just gone over people's heads. They're not hearing me, but speak to that. I know it's important.
Sure. Well, certainly. Well, a benefit of hospice is that you now have care to come into that patient's life and to assist the family members at this time of life. Being a caregiver is very difficult, and the majority of expenses in healthcare come at end of life.
Mm-hmm.
So hospice gives an opportunity to assist with that. There's a team that makes up the hospice care and treatment. There's a physician as part of the team, a team manager that is typically a registered nurse who kind of orchestrates the management of the team and the patient behind the scenes. There's an RN case manager who is the actual nurse for each patient that is brought onto service. And this nurse typically will make a visit at least once a week, depending upon the patient's acuity, more often if necessary. And they're always in contact. Hospice is 24 hours a day, 7 days a week. You can always reach somebody in time of need and distress.
Mm-hmm.
Home health aides make up the team, and they come by and can give care to the patient anywhere from 3 to 5 days a week or so. And that is with the activities of daily living. As our body declines, we lose the ability to do things that we do on a daily basis that we don't think about: bathing, dressing, eating, going to the restroom and toileting ourselves. As we lose the ability to do these things, that can become distressing and depressing. And family members might find it difficult to care for their loved one. Most caregivers at end of life is typically the oldest daughter in the family. But if there's no daughter in the family of sons and no spouses that might be willing to step in, then you're getting caregivers by males. And most men don't want to take care of their mother's toiletry needs. But it's something that does need to be done, obviously.
Right.
Well, hospice can then come in and assist with that. The rest of the team is made up of a social worker. You may not have plans in place as to where you're going to have the homegoing service, where the burial is going to take place. Are there any benefits that you might be able to access and make use of? Social work can come in and make assistance with that. A chaplain to be able to come in and give words of encouragement. And keeping in mind that a hospice chaplain is not a pastor. So yes, you may have your home church and your pastor and you get your spirituality there. But when it comes time for the hospice treatment, you might want to have the hospice chaplain as well. I personally don't recommend ever turning down prayers and encouraging.
Right, right.
There's a music volunteer that can come in and not just to play music and kumbaya and karaoke sessions. The music therapists are trained in their instruments. They're also trained to address circumstances in end of life, depression, anxiety, pain. And that's what they're doing through music and music therapy. Volunteer coordinator, because volunteers can come in and sit with the patient. Find somebody that's from a like generation or has had like similar life experiences. Our veterans, for example, you may have a veteran who is now declining in their caring condition, but there's another person that might have served with them or served in the same branch of service and could come in and share some time, giving the caregiver a moment of respite to be able to step out and take care of some personal business or just walk around the block and get a breath, because again, caregiving is difficult.
Mm-hmm.
This brings us to the levels of hospice care. Home hospice, first and foremost, where it's delivered at home, but sometimes the patient can't be at home. They're too sick to be at home, but not really sick enough to be in the hospital. And you can have what's called inpatient care. And that's where the patient is in the hospital. They're declining. They're unfortunately going to pass away, but they are not admitted to the hospital. So they're not on the hospital's roster. They're on the hospice company's roster. There's also crisis care. Person gets admitted in a time of crisis in the hospice, and that's where the nurse is going to be there 24/7 in the patient's home to stabilize that person from their pain, their anxiety, their agitation, and get them medicated and calmer, and then go back to the more routine treatment. And there is respite care, where once a month for 5 days, the patient can be admitted into a facility while the caregiver addresses some other things that might be going on in the family. They may need their own medical procedure. They may have a trip that has previously been planned. They may just need a break from months on end of taking care of someone to rejuvenate themselves and come back and continue to take care of their family. Hospice takes care of that financial component as well. We talked about hospice being end of life care being very expensive. Hospice takes over the payments of medications related to the hospice admission diagnosis. So the medications that are needed, the durable medical equipment, hospital bed, things for activities of daily living, chucks to put down for incontinence, gloves, all of that is now covered through the hospice benefit. So as you hopefully are hearing, it's not the team that does nothing, it's actually the team that does a lot. And especially for patients who have been homeless, they've ended up in an emergency department, diagnosed with a terminal illness, and now they're getting the care and treatment that they may not have had for years, with a doctor on board, nurse practitioner on board, an RN on board, a home health aide, and medications that they have not had in many years, if ever. So all of this comes through hospice and the hospice benefit.
And you mentioned the financial piece. Can you speak to two things? It first was signed in, if I understood you correctly, by President Reagan as a Medicare benefit, but then the other third parties have taken it on as well. Is that something that we as Americans are paying? Are we paying a percentage of our, of our premiums? Is it for hospice care towards the end of life? That's the first question. And then you mentioned that at minimum, you can get someone to come in maybe once a week. But is it just per scenario that is determined? Because you kind of mentioned if there's a son, or what if the person has no, children? If they've never had children or their children live away, like who and how is it determined how often someone is coming in? And really, I can be sure that a lot of my folks would be asking the question, well, when they see this, who's paying for it? Are we paying a percentage of our premiums to that? And is it all payers?
All payers do offer a hospice benefit. Now, how the payment goes for that is probably part of your premium that you're paying anyway, and it's just to give your health care. The Medicare benefit is specific for hospice in terms of it was first written in as a hospice Medicare benefit. And if you have worked, you have paid into Medicare, it is already paid for. The best way to answer this question would be that no patient that is admitted into hospice care has to reach into their pockets to pay for hospice. If they have no ability, no payer sources, most hospices will have indigent care and take care of that patient the same way as the highest paying patient would receive care. Now, to finish up a question you had asked about the differences between majority and the African American community, yes, there is a difference. We talk about length of stay. The hospice benefit stipulates that when you are determined to have 6 months of life left to live based upon how this disease process has transpired in the eyes of the physicians previously, because of course, nobody can tell you definitely when our time is going to be. So it's 6 months. Then you get admitted into hospice. What happens, part of what I do is every week, the team sits down and discusses each patient to determine how they're doing. If the patient is holding steady, that's okay. If they're declining, that's expected. If they start to improve, while that's not expected, that's a wonderful thing. They're improving. They can actually graduate from hospice and be discharged, but that is not bad. Remember, they're living. And in the event or time when their condition does indeed decline, they can always be readmitted into hospice. So the sooner the physicians make the recommendation for hospice care, the sooner the family members, the patients decide that they want to investigate hospice care, get evaluated, and get admitted, the better for that patient, because the average length of stay currently in the United States is 90 days. Remember, you can get as much as 6 months to begin with, but the length of stay for people of color is less than 7 days. And unfortunately, many times the patient gets admitted into hospice in crisis mode on a Friday, and by Monday, they've unfortunately transitioned away, not receiving all of these benefits we've just discussed. And the benefits are not just for the patient, it's also for the family. Another component of end-of-life care, hospice, is bereavement. The bereavement coordinator is active with the patient and the families, and when the patient does transition, the bereavement coordinator, the chaplain, the whole team actually stays in communication with the caregivers, the survivors, for 13 months specifically. Now, sometimes it goes longer than that based upon the patient's needs, the survivor's needs, the family members. But 13 is the number chosen for multiple reasons. One, to get past the anniversary of the death of their loved one, but also to get past the other first. The first birthday without mom, the first Father's Day without dad, the first Christmas, the first Thanksgiving, and any other special dates in that family that the patient is no longer there for, that the caregivers, the loved ones, the survivors are now mourning the loss of their loved one. So these are some of the things to look for in our current most visible aspect of hospice and length of stay is former President Jimmy Carter, who was in hospice care for 22 months. And that is tremendous. And think about it. President Carter's family most likely was not getting hospice for the economics of it, but for the ability to have other caregivers take care of President Carter and allow the family to be family, not to be going in trying to be nurses and home health aides and deliver all the other care that is required and desired and deserved at end of life. So that's where a team can come in and relieve that burden from the family.
Absolutely. Does he like hold a record? Is that a Guinness?
Well, I won't say a record. I have patients who've been on service for years, 3-4 years, but he is the most visible person that we can hold up for our communities of naysayers to see this is what this man was able to receive, what his family was able to receive. And if this is what the former president has chosen, then the rest of us can make benefit of this as well.
Absolutely. Was he kicked off? Like, okay, you may not know all of that. I'm like, what? Every 6 months he had to like re-up, like that. It was just amazing. But I do, and I have conversations with my loved ones. I'm like, they are not, everyone thinks about morphine and they're just gonna just push them over the edge. And I try to remind folks it's about the comfort and care and dignity to that loved one as well. So I appreciate all of this information, and I am so sure that our audience members appreciate it too. Um, I do have one last question because you mentioned that 13-month time frame and so vitally important as you mentioned all the first. But here's how I address with my own family and friends. Like there are just so many things that we don't think about when your loved one does transition. Is that, and I'm sure the answer is yes, but how does the hospice team help with that? When people don't think beyond their situation right now, the bank accounts, you know, dealing with, you know, do you have a will? Did you ever plan a trust? Um, what do I need to do today to prepare my family for the eventuality that is coming down the road? Is that something that hospice offers? And then you mentioned the survivor, I was about to say survivor package, but do they continue with with that paperwork about benefits? Do they continue that part of it, or is it just more the emotional support?
Now, there's a lot there, so I'll try to answer it all completely here. The social workers, that is a very important part of the team, and they're going to be the ones that can hopefully get wills in place, advance directives, nursing home placement when necessary, burial grounds. Sometimes there is nobody, there is no money, and we'll have to get the hospice company can assist with that because again, the indigent patients are not going to be turned away and left aside. And with the social workers and with our veterans liaison, there are many people who served in the United States military who have veterans benefits who may not know it. We have had patients whose spouses and families did not realize that dad had served in the wars and had these benefits because he served, came back home, and then started a family and never spoke about it. Especially our Vietnam era veterans who did not come home to open arms. So they didn't talk about that part of their lives, but they have benefits. And we have a veterans liaison who can go and get those benefits for the family members. And sometimes that can be economics where they get a check sent in because of the service time of their loved one. Now, I believe there was another question you asked in there.
The second part was just once the loved one passes, um, helping with the paperwork, the banking information. Is that a part of what the hospice team can offer the survivors?
That is something that can be offered and at least advice as to where to further take and pick up what they need to get completed and accomplished. But in the best of terms, these are things that will be addressed during the patient's stay on hospice care, and why the earlier the better to make those changes in the banking accounts, to have it where pay upon death goes to whomever is designated, to see if there's any long-term care benefits, to also, that was a question about delivering the care to home. That decision is made oftentimes by the family members and patients because they're the ones who open up their home to these individuals, and you can pick and choose any aspect of what's offered through hospice to receive. And if you choose to elect to not get a specific part, so you don't want the chaplain to come upon admission, you can change your mind as you move forward. You might have turned down a home health aide initially, but then decide that you do need one. The social workers can help patients who are eligible get things such as CCSP, where through their Medicaid benefits, they can have aides come in. And it's just that the hospice aide and the CCSP aide cannot be there simultaneously, so you can alternate. Some family members have long-term care and have the finances to be able to pay a home health company to come in and take care of their loved one. So there's all kinds of ways to deliver that care and many avenues that can be addressed to try to help out.
Thank you. Wow. I am so glad that we got you off the road from speaking, and you were able to join us this evening. Before we go, two things. You're going to take us out of here with any call to action, any final tips that you have for us. But I wanted you to repeat for us before that the website that you shared with us earlier that Georgians can go to if they, want to get ahead of their next appointment with their primary care physician or provider. What was that website? And then take us on home. Thank you.
Well, I'm sorry I don't have a specific website, but you can Google 5 Wishes.
5 Wishes. Thank you. Okay.
Yes.
5 Wishes.
And it's
Thank
a
you.
pamphlet. You can Google that and use that as the icebreaker. You can always contact local hospice companies and get an evaluation from the team as to if your patient is eligible. And if so, what's the next step there? So those are ways to get into hospice. And you may need to have me come back to elaborate on this a little further. But as we go to our call to action, remember this: we did not really differentiate the difference between palliative care and hospice care. But remember, all hospice care is palliative, but all palliative care is not hospice. In the call to action, the sooner you get involved with your family members, your loved ones, the sooner you decide that you might need to seek more help, more care for your patient, for your loved one, the better for them and their families, because the benefits are so tremendous that they can receive what is out there. And end-of-life care is hard. Caregiving is hard. Death should not be. Thank you for having me again on The Pulse.
Thank you. Thank you, everyone, for joining us. Dr. David Blake, I am so honored that you took this time. We're going to be back again. Please share the information. This conversation tonight needs to get to all of our loved ones, our friends, family, here in the state of Georgia and even beyond. But please share it in your communities and in your networks. We want to make sure that you understand that hospice care is available to you and take advantage of it. Let's give the dignity that our loved ones deserve. And for ourselves, let's plan. Thank you so much for joining us. Bye.
The content shared on this podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by our guest and host are their own and do not necessarily reflect the official positions of GSMA. At GSMA, we stand on over 130 years of medical excellence and advocacy, but we encourage you to always consult your physician or qualified health provider with any questions you may have regarding a medical condition. If you think you may have a medical emergency, call your doctor or 911 immediately. Until next time, stay informed, stay empowered, and stay well.